Okay, let's go ahead and get started here. Welcome, everybody, to Navigating Ostomy Care Tips and Techniques for Success. Thank you for taking the time to join, especially around your lunchtime, and especially to learn about this subject in particular during your lunchtime. My name is Johanna Welch. I am first and foremost an RN going on 15 years, so happy Nurses Week to any fellow nurses out there. I'm also wound care certified and an ostomy management specialist, which is what brings us together today. I really hope everyone can take away something useful today to increase your confidence with stoma care and better practice when taking care of your ostomy patients. A quick note before we get started, please hold any questions until the end out of respect for other people and their time. And then in order to get credit for the continuing education hour, please make sure to respond to all the polling questions we throw up. Okay. So quick disclaimer, this is for informational and educational purposes only. Please always consult your attending healthcare professionals for actual medical advice. And I have to say this, I am not affiliated with, sponsored by, or receiving compensation from any of the companies or brands that I might mention in this presentation. Any references to a specific ostomy product is also for informational purposes only and do not constitute as an endorsement. And all product names and trademarks belong to their respective owners. So all that jargon out of the way. So let's start with a quick icebreaker poll question. So what is your current level of knowledge with ostomies? We could have no knowledge, just a basic understanding, moderate understanding, or you already have some advanced clinical knowledge. We'll give everybody a second to answer that before we move on. Okay, looks like most of everybody has a basic understanding on here. Awesome, good, good, good. So with some experience, our goal objective today are gonna build up on that with defining what an ostomy is and different common types, demonstrating proper techniques for stoma assessment, describing characteristics of the ostomy effluent or output, and discussing nutritional considerations. We will assess the perinormal skin or peristomal skin for signs of irritation and complications, and then identify a couple ostomy products, some principles for effective management, and demonstrate the correct procedure for applying a pouching appliance. Okay. So quick facts, the exact incidence and prevalence of ostomy surgeries is unknown, but we do know that ostomy patients can be of any age. They could be young, born with it, or get one right after birth, or geriatric. Approximately 100,000 ostomy surgeries are performed a year. It is estimated 750,000 to a million people in the US do have an ostomy. So it puts about approximately 1 in every 500 Americans are ostomates. Now, along with that information, we think about the nursing workforce. And according to the Wound Ostomy and Continence Nursing Certification Board, around 2020, there was only 6,177 nurses in the world, or excuse me, in the United States that were certified in ostomy care. So given that, and then there's approximately like 3.5 million employed registered nurses in the US, that means that only 0.2% of US nurses hold a certification in this subject. This disparity really highlights the significant gap between the number of patients requiring specialized ostomy care and then the availability of certified nurses, and then especially in the rural and other various healthcare settings. So beyond the blatant imbalance, why is this important? Well, there's actually a specific Bill of Rights for ostomates created by the UOAA that outline basic rights and standards of care these individuals should expect. So this is going to emphasize respect and dignity and access to medical care, education, and support. Um, Key points really include the right to be treated with compassion and understanding. Remember, these surgeries can make people feel very vulnerable with a pretty private matter, especially in the beginning, right when they get one. They also have the right to receive proper care or proper pre and post education and stoma care, and the pre and post op education. And then they have the right to choose and access to quality ostomy products and the right to ongoing support by trained medical professionals. So it is really important as medical professionals, in spite of any of these shortages, to do our due diligence in upholding these rights for these individuals. There is also a Charter of Ostomate Rights as well, which is essentially the same document by the IOA, but it's pretty much the same document. And if you want to look up more of the rights, it's down on that bottom left corner, or you could just Google Ostomy Bill of Rights and you'll find it. Okay, so now knowing all of that, most ostomy patients will experience some sort of complications. And so why is this? Peristomal skin issues, which is the surrounding skin around the stoma, not the stoma itself, is going to be your most common reason patients require a reassessment and treatment. We also see an increase in complications when prevention and intervention strategies are not always available and accessible. And then now add to that, hospital stays are getting shorter and shorter. So it typically would take a good 1 to 3 full days of teaching new ostomates for them to get successfully, managing their stoma on their own. But patients are getting discharged earlier and earlier now. And then additionally, on top of that, we encounter the barriers to access. So there's insufficient resources, not enough clinics to go to afterwards, or access to professionals. So lack of education. And then there's a lack of reimbursement for the specialized care. So no wonder we end up seeing all these complications, right? But let's go ahead and try to bridge the gaps and see what we can do. So starting with an ostomy, what is an ostomy? This is going to be the surgical opening from the area inside the body to the outside, resulting in a stoma. There's different types categorized by which organ it originates from. And this can be from the small intestine, the colon, the rectum, or the bladder. Some of them can be permanent, where the damage is beyond repair and the organ has to be removed, or it can be temporary. So, for example, there's a flare up or an exacerbation of a disease, and the diversion is created to help give that organ time to heal. Many times I've seen this when the individual is initially diagnosed with that disease, and then a plan is put in place to manage the condition. So we'll do another poll. How many ostomate patients do you currently have in your buildings? Okay, so we have none, 1 to 3, and 2 to 6. So that's a good amount. Awesome. Well, let's see. There's a variety of reasons your patients ended up with that stoma. Some of the common indications for this will be a blockage or obstruction, cancer or tumors, those digestive diseases such as diverticulitis, Crohn's, or irritable bowel syndrome. They could end up with a perforation or an injury, some sort of trauma, or it could happen right away in life with a birth defect. So taking it back a minute, especially for nursing, what's the first step in the nursing process that they taught us? It's going to be assessment, right? So proper stoma care always begins with a proper stoma assessment. And that's where we'll really begin. So for a proper stoma assessment, it is actually all encompassing all these elements you see here. It's not just that pink red surgically created opening on the surface, not just the stoma, but we're going to take into consideration the stoma type and location, its effluent or output, and the nutrition that they're getting, the stoma color, size, moisture, texture, the lumen location, also looking at the mucocutaneous junction, the peristomal skin, and how well it's functioning. So we'll review each of these as we continue, but just keep in mind the whole time you're assessing, you're driving your interventions with each step. Okay, so there are different types of ostomy types, obviously. We have the colostomies, ileostomies, and urostomies, and they're based off of where they're coming from and what they're bypassing, really. The colostomy is the colon, the ileostomy is from the small intestine or the ileum, and the urostomy is for those tubes responsible for carrying urine. It's really good to know what type you're dealing with to anticipate any potential complications due to the different effluent or output, its consistency, the amount that's going to be coming out of it, the pH balance of it, where some of these can cause more leakage than others. So, for example, if you're looking at the table shown here, a regular colostomy might be like liquid to semi-formed, but an ileostomy might have a higher output and be more liquidy. That's a technical term. And more acidic, so that'll cause more breakdown of the appliance and of your skin faster. So if you want to take a second look real quick at the table and compare the different types. And then we will move on to nutrition. So really the type of quantity and effluent also reflects an individual's diet and their nutritional intake. If they're leaning too far, like on either side, consistency wise, maybe they're eating too much of some things, and then you can make recommendations to help thicken things up. Like there's thickening stool diet with brat, yogurt, cheese, marshmallows, all of those things listed there. Or it'll loosen it up. You can do fruits and vegetables, nuts, bran. Some of the things that might cause loosened stool could be bacterial overgrowth, alcohol, those sort of things. Maybe we have an odor issue. So certain foods can cause increased odor in the stool. You see here, the normals, the beans, the eggs, garlic, and then, or malodorous urine could come from fish or asparagus, Brussels sprouts, all that. There are odor reducing options. That seen here, you got yogurt, buttermilk, parsley, any of those you could introduce to try to help with that. And another thought is also maybe they're too gassy. So look at their nutrition. Maybe they're a little too gassy, and even with frequent burping of the system, it's exploding. It's filling up and exploding. So then you can introduce a couple things to help manage that. Okay. So anything you put in the body is going to have an effect, including medications. Depending on the ostomy type and absorption of the medication, like an absorption of the medication might vary. So for example, birth control pills may not fully absorb in somebody with an ileostomy, or you might have to give vitamins a different route depending on what kind of diversion they have. Meds can also cause complications. So to point out a few of these, you can see the antacids can cause constipation in a colostomy patient, but then diarrhea in an ileostomy patient. Antibiotics can cause diarrhea in any of them, but it will especially put your ileostomy patients at risk for dehydration. And then they're also especially cautioned with the use of diuretics due to electrolyte imbalances. What else is on here? So corticosteroids, they can also cause sodium retention and possible fungal infections in all types. So that could be the cause if you're noticing a fungal infection. And then for all of them and kind of everyone and everything, NSAIDs can cause increased bleeding and all. So if you're having more bleeding of the stoma, you might want to look at their medications for that. Okay. So when we're looking at the stoma themselves, a normal stoma is going to be generally beefy red and moist and not painful. It might have one or two openings, so don't be afraid if there's more. You might hear different various types of configurations when it comes to the openings. There could be like end stoma, loop stoma, or double barrel, but we're just going to keep it simple. One or two, or note the numbers. The stomas could be recessed or flat or protruding outward. Their size and shape can also change depending on how soon their surgery was, the abdominal pressure or going on throughout the day, or any other complications. And then stomas can bleed easily if they're rubbed or bumped, but just remember that this can resolve quickly. All right. So continuing with our assessment, because of the changes in size and shape, we want to make sure when we're doing our measurement that we're measuring every appliance change and customizing the appliance accordingly. We do this in millimeters, not centimeters like in wound care. And you'll measure, from top to bottom, and side to side and side to side. And then we can also convert those to inches if needed to match the appliance sizes. You'll usually see the appliance sizes on the sides of the boxes. So we'll utilize a measuring tool that whatever you want to measure down the base of the stoma. But that's going to be I like to use a Q-tip to go down. We can use the pre-cut circular measuring tool that comes with the wafer or the skin barrier portion of the appliance. That one's really nice to use, and you can just hold it up to the stoma. Or you can use the standard like paper ruler for other shapes, especially if it's more of an oval shape. Our other way we can measure is going to be especially for more irregular shapes, is going to be by tracing with the clear plastic backing that's on the skin barrier or wafer. So as previously mentioned, if the stoma is new, the size may change for at least like the first 6 to 8 weeks. That's why it's especially important to keep measuring every time before you put in a new appliance on. Or even if you have an established stoma patient, it could fluctuate if they have changes in their weight, or if there's an increase or decrease in edema. So yeah, proper measurement of the stoma is really going to ensure you're not leaving behind any large gaps of exposed skin vulnerable to the breakdown by the effluent. The next we're going to do, we'll measure our stoma height. And like I said, I like to use just a Q-tip and measure that from the base of the skin up. For this patient, you can see for their shape and height, they're about, I would say it's round oval. This person actually kind of went back and forth between both. And then they measured out about 20 to 25 millimeters. So the stoma height and presentation are going to be really important because they are going to, they're pretty key in driving the management and interventions. For example, if it has no height and it's pretty flush with the skin or retracted below the level of skin, the goal is really going to be used an appliance or an accessory to help push it out past the level of skin, kind of like up in that top right photo here. You can see it's pretty flush, so we're going to want to push that out so that the effluent goes beyond the wafer. The stoma can be the opposite of that, which is going to be prolapse, where it's kind of telescoping out down into the bag. So we'll want to make sure to allow more room for it and protect it if that's the case. And then a common complication, a really common complication of poor placement of the patient might be putting the stoma in like a crease or an abdominal fold. So this can easily cause a leak if we're not noticing it. And we're going to make sure we'll go over it later, to build up around that area to prevent any of those leaks. Other complications we see can be a PG stoma, or that is pyoderma gangrenosum. That one is going to be in the bottom left photo. And what can happen with these is you can end up with a rapidly evolving ulcer. The stoma could also incur trauma and become lacerated if we have an ill-fitting wafer. If we're cutting that too close or not giving it enough room to expand, then we can actually cut it. And then the other one is a peristomal hernia. So that's going to be a bulge. That bulge is making like the surface rounded, and it's harder to keep the appliance on that. So that's going to be shown in these middle two photos here. You can see the big bulge of that hernia pushing up around. So to put a flat wafer on that can be pretty difficult. Right. So the next area of assessment is lumen location. The lumen is going to be the actual hole where the effluent comes out. You can see that I'm pointing on that guy right there. It's the little middle guy on these guys. Ideally, the lumen is going to be centered, like in picture A. But if it's not centered, we note this using the clock method. So on this one, we're going up towards the right, towards, like 2 o'clock. And then on picture C here, it points down towards 6 o'clock. And why is this going to be important? Well, because the lumen direction is actually a good indicator of which way the effluent is going to go first. So in photo B here, it's going to spout off towards 2 o'clock and then kind of trickle down here, pool down. And you can see that's exactly where this person is experiencing more breakdown, because that's the part that's getting hit first. We're going to need to do an additional intervention on that, obviously. So, and then if a lumen is pointing straight down, like here in photo C, or is like on the inferior side of that stoma, then it's going to be more likely that it's going to actually just go up and underneath the wafer when it's spraying directly down. So we'll want to push that up so that it's not going up underneath the wafer. Okay. So we're kind of doing our normal assessment, like medial out. We've done the stoma. Now we're getting to the part where the skin meets the stoma. So this is the mucocutaneous junction. That's where the mucosa transitions into the skin. If there is separation noted at this, it can indicate compromised healing, and it could be caused from surgical site infection, tension on the bowel, inadequate approximation of the mucosa when it's made to the dermal layer, or also it can be from too much pressure on that junction immediately after surgery. So if we're going to have an issue with this, it generally is going to be within the first month of surgery. We just want to make sure that that's nice and intact and that it's not separating from the skin around it. So we'll do one other poll question now. What challenges do you or your patients face most often? Okay. Lots of people are saying skin irritation and leakage, definitely diet and some, emotional and psychosocial issues. All right, awesome. So we will look into all of these guys. But with the leakage in the skin issue, that's going to be the number one, one of the number ones we always see. So that we're going to be looking at the surrounding skin next, and peristomal skin protection is huge. It's considered the cornerstone of ostomy management. Once it's compromised, then we end up in this cycle of skin breakdown and issues with appliance adherence. And then, the skin is open, it is moist, the wafer is not going to stick to it as well. And then we're going to end up causing more leaks and more breakdown, causing more adherence issues. So it's really this revolving cycle once there's something happens. Treatment of the skin really relies on methods to create dry surfaces, filling in any of those irregular contours, and treating infections, all while maintaining that adhesive seal. And remember, prevention costs less than treatment. And so with good assessment, you can easily identify those problem areas before they become a problem and we end up in that crazy cycle. So for reference, your normal peristomal skin should really look like the regular skin on the other side of the abdomen. If you were going to do a comparison, so I'm looking here at this peristomal skin, and does it look like the normal skin over here? If it doesn't, then we have an issue. It really needs to look intact and dry with no erythema, weeping, lesions, or ulcerations. And that sounds like a perfect world, but you're probably here because you don't see a lot of stomas like that. So we usually end up seeing stuff like this. What are we going to do when we encounter these abnormal peristomal skin complications? So let's identify a few of these and look at treatment solutions on what we can do to break that cycle of adherence issues. So first, probably the most common that everybody sees is going to be your peristomal MASD, that pesky moisture-associated skin dermatitis. To treat it, you first want to assess actually the back of the old skin barrier or wafer to identify a source of the leak. And when I'm saying that, I mean, you want to look at the back of that hydrocolloid because it's going to swell up and slightly change in color where there's been excess moisture. And so that can kind of pinpoint where the issue is coming from. So next, then we're going to refit the pouching system and consider possibly using a convex barrier if appropriate. We'll touch base on convexity here a little bit later. Or we can also build up those crevices around it to that prohibit your barrier from laying flat up against the stomach. Then we want to treat the affected skin. We can do this with stoma powder or antifungal powder, or we can consider using the crusting method, which we will also go over. And always want to ensure to empty the appliance when it's a third to a half full to prevent it from pulling down. Because if we're pulling down and tearing, then we can cause a leak. And then also we want to make sure to burp the bag if it's filling up with gas and exploding, of course. So in this picture to the right, I'd probably start by crusting all that denuded skin and then address those contours by building it up with a sort of paste or a barrier ring, whatever I have, before placing that next skin barrier or wafer. And then just a quick side note, MESD and contact dermatitis from allergies can kind of look the same. So if you notice that you pull it off and there's a weeping area, but it's matching the entire space of that wafer, like a perfect circle, you might want to consider switching products because that could be an allergic reaction and not from a leak. Next issue we see is peristomal MARSI or mechanical skin injury. It's most likely caused by an improper appliance removal. So we want to utilize and teach your patient to do proper removal techniques when this happens. When we're removing the pouch off, we like to say to go low and slow. So hold low and go nice and slow and don't rip it off and don't go pulling it out away from the patient. After that, we'll refit and adjust as needed. You can also slightly place the skin barrier over a little bit so it's not going right back onto the affected trauma area, and then use skin protectant as needed. If the affected area is bad enough, though, that it's causing like a skin tear, you're going to want to treat the wound as you normally would and just do that up underneath the pouching system. Okay. And then our next one, our last common peristomal issue that we're going to review today is peristomal folliculitis. This is caused by irritation and infection of the hair follicles on the abdomen, more prevalent depending on how much hair somebody has. The treatment recommendations for this is going to be atraumatic hair removal or pretty much just trimming with scissors is what is recommended. That's what I recommend as well. We're not going to use any Nair. We're not going to go waxing anybody's stomach. We're not going to create more holes to get infected. Best thing to do really with this is going to be just to trim it nice down and low. Then we're going to make sure to wash it, get all those extra hairs off. Wash it, rinse it, dry the area really well, really thoroughly before placing your next appliance. If you need to, you can consider using an antibacterial wash. Just make sure to get all the soap off, of course. Make sure you rinse really well. And then if you're not seeing any improvement with this, then the next step would probably be to get a culture. Okay. So we've done our full assessment. A full assessment is going to deserve thorough documentation. Here's a good example with pretty much all the components that we had on there that we reviewed. So patient has an ileostomy in the right lower quadrant. Stoma is beefy red and moist. The stoma measures 29 millimeters and is circular in shape. Its height is 2 millimeters. And we have intact, centralized, single lumen. Edges are intact with no concerns to the mucocutaneous junction. And the peri-wound is pink and intact. Then you're always going to want to note the effluent. So soft brown effluent noted in pouch. And if you do have somebody that's on I's and O's and they're supposed to be tracked, then you can also add, those I's and O's that you're pulling from there. Okay. So we did our assessment of all the assessment. Now let's look at management. So our goals is to always keep the stoma nice and moist and then have a dry, intact epidermis. So once again, prevention costs more than treatment, but we're going to start with cleansing. We're going to use soap and water. We're not going to be using anything that's abrasive, and don't want to use any kind of surfactants or wound cleansers because that's going to mess with the adherence. Then we're going to make sure we have a proper appliance fit for each individual stoma site, and then continue to have a good routine of skin care, nutrition, and exercise for these individuals. And then we'll make sure we have proper maintenance of the pouching system as well. Okay. So normal wear time of our appliance is actually multifactorial. This is going to depend on the location and surgical construction of the stoma, the type of the output coming out, the condition of the peristomal skin, the presence of moisture. Where do the people live as well? Is it humid outside? Are they sweaty? Are they somebody that wants to go swimming? That might increase moisture. And then use of the appropriate equipment and proper application techniques and frequency of emptying. So once again, like I said before, we want to make sure to empty it when it's about a third to a half full. Generally, typical wear time is 3 to 7 days with a max of 7 days. We may have to adjust or increase the frequency of these changes when overcoming any hurdles like MASD to avoid leaks. So it seems kind of silly. You're trying to keep it on, but you're taking it off more often, but just to be able to reapply whatever we need to on that peristomal skin to help it out. Individuals should really be able to rely on their pouching system, though, for a secure and consistent performance. So that is our goal. All right. So for ostomy skin management, we want to make sure if there's any open skin, that we're going to treat it and cover it. And then if there's any intact skin, we're going to make sure or for the intact skin, we want to cover that and protect it. We're going to keep the system patent and monitor the output. And then we want to prevent any leaks. But if we do encounter any of them, we're going to want to fix the cause and perform prompt placement of a new system. Let's take a look at what we have in our tool bag. And we'll go over some ostomy supplies and their uses. And give me just a second here. See if I can do this for a little bit of show and tell. Okay. Hopefully that works. You guys can see me. Hi. Okay. So first thing that we're going to be using is skin prep. This is going to promote the skin health and integrity. It is a barrier for the skin, and it can come in these little wipes, or we can use the spray. And I like to use the spray a little bit better, especially if I'm going to be doing crafting. But what this is going to do is it's going to enhance the adhesion of the wafer for the intact skin. Okay. Next, we have ostomy paste. So this is an adhesive hydrocolloid mixture. It's used to fill in and caulk in any of those uneven skin contours that we find. And that's going to help create that flat, even surface to prevent the effluent from getting up underneath the ring. It does contain some alcohol, so you want to make sure that you can notify your patient. It can cause some stinging if you're applying it to some denuded or open skin. But the other thing is it can be a little bit difficult for patients, especially if they have dexterity issues. So there's other options for that. Look at that guy next. So other options would be to use an ostomy ring. This is what it looks like. It is just a hydrocolloid ring, excuse me, just like that. What's nice about this is it's easier to apply for people with dexterity issues. It still gives that second layer of solid skin barrier. It also, because of the thickness, can add a little bit of soft convexity if you need to just pop up an area. There's not any alcohol in this, so it's not going to cause any pain. And then you can also put it in place of, so yeah, you can put it in place of the wafer, but you can also place it directly on the wafer when you're going to apply it up to the skin. It stretches, so that's really nice when you have a stoma and you want to make sure to put it up nice and close, and we can measure and place it over while it's intact. There's different sizes, so you want to make sure you use the right size and the right thickness. The other reason why I really like the ostomy rings because if you're cutting your wafer, say I cut my wafer and I cut it too big. This is going to give you more room for error if you make sure to put this up against the stoma and then place the wafer up and over. So you're not leaving that gap up against the skin. Next, we have our ostomy powders. So ostomy powder usually looks like this, and one of the main ones I usually see. This is going to be used to absorb moisture from any of the damaged skin. So you have that open skin, you have the moisture. The appliance isn't going to stick to that. So we're going to powder that, use this powder on that, and that'll help so that it'll adhere better. We use this for the crusting method, and we'll go over that in a second. But also, if you think you have a fungal infection, then we can do crusting with a miconazole powder. This is like your normal 2% miconazole, house miconazole, or you can use nystatin powders as well. You always want to treat the surrounding skin first. Okay, so the crusting method. First, with that, we're going to cleanse the skin with normal lukewarm water. And if soap is needed, we want to make sure to rinse the area really, really well to avoid from anything, to make sure that it doesn't stay on and then your wafer won't stick. So we'll cleanse it really well, pat the skin dry, and then we're going to apply a thin layer. I don't know if you guys will be able to see me well, but let me try to practice here. So say my skin is wet. So then I'm going to just do, we'll see how you can see it. Don't know how well you'll see. But I'll do a nice thin layer of the powder. And then we want to make sure to brush off the excess so it's only sticking to the open areas, okay? We'll do that. Please don't blow on it. I've seen some people come up and blow on. Don't blow on your patient's stoma. So we'll do that. And then we're going to use the skin prep. That's why I like the spray, to just do a nice little even area, nice little even amount there. And you want to make sure to let that dry. And then you can do multiple layers of this. We just want to make sure to always do thin layers so we end up with a crust and not like a big scale, because a big scale will make it pull off. So we'll do it again. We'll powder it. Okay. And then another spritz. It might be kind of hard to see, but now we're protected. So that's your crusting method. You can repeat it like 3 to 4 times over heavily denuded skin, and make sure to reapply it with each pouch change as well. Some of that will come off. We'll want to clean it down, and then we'll add it on. Okay. And so next, we're going to look at the abdominal assessment. So anytime you're looking at your stomach, when you're going to figure out what you're going to apply, what you want to choose, really. If you have a soft abdomen, we're going to make sure to use a firmer support. Whereas if you have a firm abdomen, we're going to make sure you use a soft, flexible barrier. Also with your crevices, if it's shallow, we want to use like a paste to fill that in. And then if it's a deeper one, though, we can use these other fillers and like those rings that are more flexible and firm. Okay. So our first guy we might want to choose from is our flat wafer. Pretty sure everybody has seen these guys. This is going to be your preferred choice for stomas that are protruding out. They're used for the firmer abdomens and usually are okay to use for most ostomates to start. When you're going to use your wafer, no matter what, you want to make sure to warm it with your hand, just like that, because with the warmth against the hydrocolloid is going to increase that tackifying ability and it'll stick a little bit better. So we're going to warm it before, and then we're going to place it, and then after application, we'll do a little bit more warming on it to increase the adherence. All right, and then when it comes to convexity, to convex or not to convex, like, so what is that? Convexity presses on the tissues around the stoma, which increases like the degree of the stomal protrusion. So it's going to push it up and out. This is going to reduce the risk of any undermining of the stomal output up underneath the pouching system. So convexity will also fill dips and support the soft abdomen. And we really want to use these for soft abdomens and for those flush or those recessed stomas. So let's see. We do have one. Here we go. So if you can see the difference here, this guy is pushing out and this one's pretty flat. So this is going to push the stoma out and pop it up above skin level. Okay. So as we'll go over our pouch types, they can come in 1-piece or 2-piece systems. Our urostomy is going to be drainable with a valve. So we have a couple of those guys here. Be a little bit easier. Hopefully it's not blurring too bad. This is another type. We have a drainable one for your urostomy. These are nice because you can connect them to a leg bag during the day or connect them to a nighttime bag. Other than that, we have our colostomy and ileostomy ones. And a lot of times you'll see like the lock and roll, or it might have a clamp. There's different options for the ones with charcoal filters up at the top. That can help with gas management. And then you just always want to look for the stickers that come with those guys so that when you shower the patient or if they shower themselves, you can put the sticker up over the charcoal filter and then it won't get it wet. Next, we have barrier strips. These guys are used to enhance the seal on the outer edge. So when I'm saying that, I mean the outer edge of the wafer. So you have our wafer. This is up against the stomach. Our barrier strips are going to be put on the side to enhance that seal on that edge. Okay. They're really not needed most of the time if that seal remains intact on its own for the proper wear time. But it's helpful for those with like peristomal hernias or a stoma in the middle of a crease of the skin, or if somebody is really active. I've had patients before, they were up mowing the lawn, they were doing all kinds of active things. It just really helps with like comfort and peace of mind for those patients so that it doesn't get pulled off. Okay. And then we're going to look at stability options. So we want to make sure to use an ostomy belt or a binder if we feel like it needs to be stabilized a little bit more. It might also give your patient a little bit of extra confidence and security to wear something like this is a stealth belt. Just kind of like a fanny pack. So the pouch can go up and under through here and wear that on them up underneath their clothes, and it'll help push it up and help them feel secure up against them. It can also, the belts and binders can help enhance convexity as well and ensure a better fit with that skin barrier. And then, but if you do want to, I don't think I have an example, but make sure if you want to use a belt, you are picking a wafer that has the little tabs you can see on here, the little tabs on the side for that to click up into. Okay. So next we'll just go over a quick pouching procedure system. Anybody that has not done it. First, we're going to start with the assessment of the old system, right? So maybe they had a leak. We want to see what's going on up underneath there. So I'm going to take this off the patient. I'm going to look at the old system. I'm going to look at this hydrocolloid and see if I have any swelling or if you can notice the leaks on which area that's been going. And when you flip it around and look at your patient, I can tell on this area of the stoma, that's where they've been having an issue. Want to make sure after cleansing and fully drying them that you're assessing your patient in multiple positions. Just because somebody's laying on their back, you might not see the issue where there's a contour, an abdominal fold, or something like that. But I like to assess people when they're standing and then when they're sitting and laying flat on their back, just to make sure in different positions there's not something that we're missing. Also, ask your patients if they are with it enough, what worked, what didn't work with them in the past. They'll know, they'll be able to be verbal. Maybe they really love a certain product, they don't want to change, so we'll just go with that. Then we're going to end up we'll take a look at our stoma and we'll fill in any of those creases or crevices with our paste or our rings or also our strip. And if you can get creative with this stuff, you can do just a half moon of this. Maybe it needs to be doubled up on one side. So just look at where those contours are and fill them in. Take your time with that. And we'll make sure that the appliance stays on the appropriate amount of time. Next, we're going to protect it. Of course, we're going to use our skin prep and place our wafer. We want to make sure that when we're placing our wafer, we've measured. Okay, so actually, 1 second here. Where's my other guy? So we've measured our stoma, right? And we've used it. This is the little circular guy I was talking about. So we know what size. Sorry, that's kind of blurry. We've measured our stoma. And then we're going to cut our wafer. And a good trick for this guy to make sure we're really protecting the skin around it is going to be to do little cuts all around up until the area or up until your line that you need. And that's going to make it easier to cut all the way around. And in order to protect the skin, the surrounding skin, we don't want to cut a huge hole and place it around the wafer, or excuse me, around the stoma. But we want to make sure to cut it about 1/8 of an inch up until the stoma. So leave 1/8 of an inch because that is going to be, that's going to allow for any swelling and edema or with their movement. And we're going to make sure that we're not actually cutting or lacerating that stoma. Okay, we'll protect that and pick your matching appliance to go up with it. And then we're going to protect it and cover it and hold it. And so you want to make sure to apply some sort of heat, either by holding it with your hand, having your patient lay flat and splint if it's a difficult one, or you can also just fill a normal glove with some hot water, not too hot. You don't want to burn your patient, but fill this up. And then you can place that up against the appliance up on their stomach and help that hydrocolloid adhere. Okay. So, a couple other things. Give me 1 second. All right, we'll go back like this. A couple other considerations we want to look at are emotional issues or any learning barriers with your patient, and really looking at different adherence strategies with them. So some emotional barriers, we can look at that on the next slide. But learning barriers, we can have cognitive, physical, or environmental barriers with these patients. Cognitively, they could have informational overload right when they're getting out of the hospital, or they could have some sort of cognitive impairment. But if you think about it, you have this new surgery, everybody's trying to teach you everything. It might just be too much for these people. So you'll have to go over it a couple more times with them. Physically, so that these patients could be fatigued, they could be in pain, They could have limited mobility that's causing it so they can't manage their system correctly. Or like with our elderly ones, we have reduced physical dexterity or vision problems. So want to take those into consideration when picking a system or trying to help them with their system that make it easiest for them. Environmentally, like I said before, these people are getting rushed. They have rushed hospital discharges and lack of access to stoma care nurses or follow-up resources. So things can become like we can get inconsistent information from different providers, and that's going to lead to um, adherent, or that's going to lead to less adherence. Excuse me. Okay. So psychosocially, never forget that there's a large psychosocial effect or ostomies on these patients. They can have body image disturbance, low self-esteem, depression, anxiety, social withdrawal. They'll have intimacy or sexual concerns, and then they can also lead to denial or anger, grief and loss, and embarrassment, or there's kind of experience a sense of stigma around their stoma. Want to make sure that these people have support. If there is a lack of support, we could try to find some resources or community resources. There's support groups and organizations within the community that we can help with. But really, yeah, these issues can all hinder the individual's adaptation process and ability to compromise and has the ability to compromise their capacity to effectively manage the stoma care. So all of this is going on. It's going to be harder for them to actually self-manage. All right, so what else can ProHealth One do for you and your patients? Well, we can help provide more education. We're ensuring that your staff is well trained in ostomy care and that will help lead to fewer complications. We have a couple of ostomy certified registered nurses that can provide training and in-services in your building for your staff. Also can do evaluations of any complicated patients and hands-on teaching while in the building as well. We can do one last poll here. Would you be interested in any follow-up sessions on any of the following: advanced stoma care, managing complications, or mental health and adjustment, or product demonstrations? We'll give it a second for everyone to finish answering. Okay. So looks like, yes, we'd be interested in some more advanced ways of stoma care and other managing complications. Awesome. Product demonstrations are also great. There's so many products out there. We're not limited just to what the hospital is discharging somebody with anymore. Really, you can MacGyver if something might work perfect for one patient and not at all for the next patient. So it's really awesome that we have so many options now. Also, we can help you out. We do have an outpatient clinic. We do have ostomy care and education at that clinic. If you or your patient are anywhere near the Littleton area, for any patient referrals for that, you can go to our website, prohealth1.com, and click on the clinic tab, or you can send us an email, clinic@prohealth1. We also provide wound care services. There are additional wound care services that might not be in the buildings where we have providers. So we can do total contact casting. We do a vaporox therapy or moleculite testing on these people. And then for ProHealth One, for overall contact, that information is on the right-hand side for our main office, fax, email, and website. Okay. Additionally, we do have a couple upcoming webinars. We're going to be doing these every month, except for next month, but our upcoming one is going to be Wednesday, June 4th. This is going to be over wound care and legal compliance, understanding your risk and regulations. And then we will be taking a break in July for 4th of July, but picking things back up on August 6th. Okay. Awesome. So thank you for joining. Does anybody have any questions?
There is a Q&A section on the bottom that you can type your questions in anonymously if you would prefer to do that.
I can't really see. So you guys see any? I can't see any of that if there's no questions.
I'm not seeing any questions on our end, Joe.
Okay. Awesome. Well, thank you everybody for joining. I hope something helped with something, and go ahead and reach out to us for any more education sessions.